Good afternoon. We have a small but select and discriminating audience today, but there are somewhere always between 200 and 400 of NIH colleagues who are watching live. So we encourage you to ask questions during talks, afterwards, and the only thing I'd suggest is wait until we can get a microphone to you, because I keep getting emails saying the answers were wonderful, but I wonder what the questions were. So let's see. You haven't been here before, have you? Who hasn't been here before? Okay, what's that? Right. Okay. So why do we show the Brooklyn Bridge? Very simply for three reasons. One, because my grandfather took that picture back in the 1880s. The second is the whole purpose of this course is a bridge building exercise. The whole idea is to get people who know a great deal about very reductionist science, particularly at the student and postdoc level, to be exposed to some of the major clinical problems, but presented not in a formal clinical way, but more like a Scientific American level to acquaint you with what a disease is like. You hear words, and much of the public information about these diseases, much of it is badly miscast. So here we have some of the world's great experts in these various things. So we bring together, most of the time, a live patient and a translational clinical investigator and a more basic science. That's the general formula. It gets mixed up from time to time. And so the whole idea is that we are on the catwalk crossing over to Brooklyn. And once you build a bridge, life is never the same on either side. That's the whole idea. So hopefully everybody will learn something and be excited by what they learn. The intent is not to have you write down like a old-fashioned medical student or graduate student, everything somebody says. Okay, having said that, there's a final exam for this course for those listening and here. If you attended 50% of the sessions and logged in, and then starting next week, you go to the website, and there's a multiple choice set of questions, none of which are going to keep you up too late at night, but hopefully we'll deal mainly with the important highlights of the various topics and things that were discussed. You can take it as many times as you want. Once you hit the passing grade, you'll get a certificate from the NIH, which has some intrinsic value, but I wouldn't want to use it to ride the metro with or anything like that. Okay, now I would also like to mention to folks listening in here that next week we really have an extraordinary event. Tom Kremikas, anybody know who he is? All right, you recall the exploration of Pluto about a year ago, the incredible photographs and okay. So Professor Kremikas is the man who directs the entire robotic space program for NASA, for Hopkins, and he's the director of the Applied Physics Lab at Johns Hopkins. An extraordinary man. And he has been responsible for the exploration of every planet in our solar system. And so Tom is going to speak about robotic engineering, astrophysical exploration. And he's also been the chairman of a national group that for several years has been discussing and analyzing the problems of human flight. And so that is where the link is to the NIH, because somewhere along the line, if this interest expand further, there's great concern about the major biological and even physical problems associated with prolonged space flight. And that's where science comes in. And so I don't know that NASA is going to become another NIH, but I do think that this area of space travel has great implications for people in biological sciences, aside from the whole Star Wars aspect of it. Then the last session of the course, a week after that, is one that was postponed because we had a snowstorm. Hard to believe on a day like this. And that's one on, it's on aging. And the two speakers, one is the director of the Aging Institute, the clinical aspect of it, but the other, Dr. Barzilon, is from Albert Einstein, and he studies centenarians, 100-year-old. What do you have? What do you need? How do you get that far? And what's life like? It's really an extraordinary analysis of the aging problem. So I just mentioned those things to you. Okay, so I think that the topic of today's, oh yeah. So does anybody know what these people have in common? Second part of the quiz. Okay. Well, of course, the top four won the Nobel Prize for studies of cholesterol. And the bottom four, although not specifically studying cholesterol, their work very much fed into, was related to, such as Kendall and Hench and other studies of steroid hormones and the relationship to cholesterol and so forth. And even Pavlov, interestingly enough, I was surprised to find that there's a paper by Pavlov where he analyzed the gallstones in a patient and said, these are crystals. And he didn't name it cholesterol. A Frenchman did a short time around the same time. But cholesterol attention, interest, came out of the finding of this crystal material that accumulated in the gallbladder. And then it led through a biochemical era, Bloch and Lennon in particular, who described, I think it's 37 steps that are involved in the conversion of acetate to cholesterol. Maybe there are more. But this was a real biochemical tour de force. And of course, what they were dealing with, the sterol, is highly insoluble, and so it circulates around, bound to proteins, and it's an essential part of cell membranes. If you have too much of it, it's associated with atherosclerosis, stroke, and so forth. And if you have too little of it, particularly not in the right place, that's not good either, because it's really essential for life. For cell membrane structure, it's a precursor for bile acids. In fact, that's how bile acids are formed, this intensely apolar substance is converted into a detergent, which is essential not only for digestion, but also for, now we're learning, many signal things, vitamin D production and steroid hormone. Now, one of the intriguing questions, which is going to be discussed today also, is that sterols like this are not unique to animal food, which we all attribute eggs, cheese, meat, and so forth, which have a good bit of cholesterol. But the biological world has a lot of sterols that also have similar properties, a notable one being cytosterol, which is present in plants and vegetables. And we consume, dietary-wise, huge amounts of plants and vegetables. That's what we're supposed to do. Eat your lettuce and exercise or something. So why don't we get into trouble? Because cytosterol chemically is very closely related to cholesterol. And we don't because the liver has a capacity, a special transporter pair that pump it out very effectively. Not so effectively for cholesterol at times. So you might consider, why don't patients get cardiovascular disease from eating too much vegetables? And it's because of these transporters, ABC, G5, and A. But when they're mutated, then things happen, which you'll learn about today. So our speakers today are experts in this area, this field. And I will briefly introduce them to you. So, okay, so the first speaker is Bob Shamburek, who received his medical degree at the University of Virginia, where he trained in gastroenterology and gerontology. Since coming to the NIH, he's been the head of the lipid service and is very much involved, as you'll hear, in the question of primarily the lipoproteins that are related, by which cholesterol gets moved around, but other aspects as well. And our second speaker is Denny Porter, who got his MD and Ph.D. from Washington University in St. Louis, trained in pediatrics and genetics, came to the NIH in 1993, and has been here since. Now, he's particularly interested and well known for his studies of inheritable disorders related to predominantly cholesterol, and he's going to tell us about it and some progress that's been made in understanding the mechanisms and the management of these diseases. So we're very grateful to both of you, and maybe you would begin, Bob.
Thank you. So I'd like to thank Win for inviting me here, and I think one of the important things he says is to be, I think, successful in translational medicine, you do have to be a bridge builder. And with our rounds, we actively include the PhDs, and I certainly couldn't survive without cell biologists, animal physiologists, vaccine, you can name it, in order to understand these lipid disorders. So I would like to give you an overview without having a real patient of about 8 different disorders, all of which we follow here, but I think we understand cholesterol, and we will be able to answer the question he shown right near the end. So I have no disclosures. So typically when we think of patients with lipid disorders, on the left we see a heart attack where the cholesterol is greater than 250. Frequently that's a genetic disorder. And on the right, the other disorder we sometimes confuse, but triglycerides is not cholesterol, it's another lipid, and it can inflame the pancreas and give us pancreatitis. So, I should probably start out with saying, what is an average patient? What's a healthy person? We know about the incidence of obesity and increasing. So what has really happened? We go back to 1504 with David, good life, active. He's quit exercising, no more marathons. He gave up his Mediterranean diet now. He's on a high-fat, carbohydrate, junk food diet. He's drinking excessive alcohol. He's gaining weight. So what's happened to him? He's developed the metabolic syndrome. We heard about fatty liver. We heard about insulin resistance. And in fact, diet, this is his copycat, his cat, Tabitha, who's picked up his bad habits. We're teaching our children, things like that. So diet and lifestyle play a very important role in obesity. But what I would like to really do is focus more on the genetic forms. So we know atherosclerosis, hardening of the arteries, is a transitional thing where you go from fatty streaks to lipid to thrombus, and you can study those specific genetic disorders, but I'm involved more with the lipids themselves. So atherosclerosis isn't something that happens overnight. In fact, one person said there's no such thing as sudden death. It takes decades before you end up with your fatal plaque. Then once you're trying to do a treatment, you're looking at patients here, and then are you trying to reverse? Are you trying to prevent progression or just maintain it here? So our treatments, I'm going to just very barely talk on, but every field in here, probably someone could have an effect in the lipid field as far as treatments nowadays. So genetic causes, we kind of started out high cholesterol, low cholesterol. I'll kind of mention a couple of those. This is a young person. We sometimes even have them as young as 3, 4, 5, 6 with homozygous FH, 1 in a million that get heart attacks. And then on the right is a 17-year-old with his face from the metabolic basis of inherited disease with A-beta lipoproteinemia. It's someone who has a total cholesterol of only about 40, but their triglycerides are low. With him, it's not an issue of too much cholesterol. It's what the cholesterol transports, which is vitamin A and vitamin E. So what is the role of lipoproteins, LDL, HDL, and lipid metabolism? I really think the reason we have lipoproteins is to move triglyceride around. Triglyceride is energy. We eat the food, we've got to get it to the liver and the muscle, then we have to be able to get it out. And the way we do that is triglyceride is energy. So cholesterol, if you try to make a vesicle or something made out of just a phospholipid and triglyceride, it's very hard. What really makes it in the human body, when you can put a protein around it, and then cholesterol is more of a membrane stabilizer. But we do need cholesterol as precursors for other things. But I think this is probably a key slide in understanding a lipoprotein. It's not a bilayer, it's a single layer of phospholipids. The major one is phosphatidylcholine. We call that lecithin. And inside the core is our fatty substances, mainly triglyceride, which we're trying to move. On the outside is mostly water-soluble free cholesterol. And it's free because it doesn't have a fat group. And another name for a fat group is an acyl group. But one of the key things, and what we'll talk about of once the plaque is put down, but to removing it, is in order to convert this free cholesterol into a cholesterol ester. By adding on an acyl group, you form an ester bond, and now it's become hydrophobic. So a water-soluble to a fat-soluble, and what is that going to do physiologically? It's going to change free cholesterol on a disc to a sphere with cholesterol ester, water-soluble, fat-soluble. And how are we going to do that? This is lecithin. So lecithin, cholesterol, acyl, transferase, forming the fat-soluble. And what this does in the body is turns it into a taxi, so that it is programmed, it has to go back. The plasma half-life of free cholesterol is about 25 or 30 minutes. The half-life of cholesterol ester, its stuck is several days. So it is, I think, one of the really important players. If you look at it from a kind of a cartoon, this disc with the free cholesterol converts over here, and that's going to be very important. And I think at the end, maybe we can talk about why HDL has been given a bad name, because I think they're going after the wrong things. So this is the overview of lipid metabolism. I'm going to give you initially a cartoon one and then go more one through a biochemical one. So we eat food, the intestine, we get triglyceride in a truck, and basically this triglyceride chylomicron particle is going to dump some of its cargo in muscle, but the rest of it is going to get into liver. And we've heard lectures on fatty liver and where this could become a problem. But this only occurs when we're eating a meal. In the fasting state, the liver then starts getting rid of its truck of triglyceride through the endogenous. This is the exogenous. So this is going to go through a cascade as it removes its triglyceride. And as it goes down the cascade, a lot of it will be removed by the liver, but if it isn't completely removed, it's going to get to a peripheral cell and start being deposited in arteries. So that's the synthesis part and deposition. Then we have to have the catabolism, or the clearance, and that's what we'll call reverse cholesterol transport. And that's where we're going to convert free cholesterol into cholesterol ester, which then destines the cholesterol. Here, cholesterol is just passively along. It was getting rid of triglyceride. Here, we actually want to get the cholesterol back to the liver and out through the bile. So this is, for a clinician, kind of our fasting lipid profile. We get a total cholesterol, which is all the cholesterol. And in fact, the total cholesterol is what's in that VLDL in the fasting state, HDL, and LDL. So we get two measurements on a lipid profile, and then we also have triglyceride. And a researcher back 40 years ago, Friederwald here at the NIH, figured out that we couldn't get a good measurement of VLDL. But in a fasting sample, when it's under 400, he found out if you take the triglycerides and divide it by 5, you can get a good estimate of what the cholesterol is. So if you have a triglyceride of 100, the cholesterol is about 20. So with this equation, we also can't usually directly measure LDL, and I can talk about that later if there's interest in that. So we can measure this, and we can estimate this and have a good idea. So this is usually how we think LDL is bad and HDL is good. But I'll show you where now stuff we're doing here kind of shows there's good and bad of both of those. So if you just look at a sample, if you are up here and I told you, who do you think, which sample has the highest total cholesterol? Let's say who has 1,000? Well, the answer is not this one. It could be this one. Cholesterol doesn't do anything to the sample. It's only triglyceride. So we can put this in the refrigerator overnight. I can spin it for 10 minutes, and the laboratory is going to say this is lipemic. But if I look at this part I can tell is coming from the intestine. It's cream just like what you'd take out of the refrigerator. And this is turbid. So this is coming from the intestine. This is coming from the liver. I can understand a little bit about the physiology. Then what we also noticed was this VLDL to IDL to VL to LDL, getting rid of the triglyceride, and then we're left with the cholesterol particle. In the non-fasting state, we have to deal with the chylomicron, which is why I often like a fasting sample. But we noted that there are differences in the proteins and there are differences in the fat content. And that's one of the ways we initially separated our particles. So Dr. Fredrickson here at the NIH was really famous about taking the plasma and putting it on paper or agarose. We still do this in the lab. And he would get an alpha, a beta, and pre-beta. And people with heart attacks had increased beta. People with no heart attacks had high alpha. The one patient we saw with a wheelchair had A beta, so he didn't have that. Some of the original names came from this. But then if we don't have charge, we can look at density because there's different amount of the fat. So that's where the ultracentrifugation has came, and that's classically where we get high density, intermediate, and very low density. We put it in sodium or potassium bromide and spin it very high, 40,000 revolutions per minute, 24 hours, cut it, adjust, and it's very tedious and goes over about a week, but that's really how we found out that this LDL was the beta. But in a lab commercially, nowadays we have to do precipitation methods. So what we're trying to do here at the NIH is go through another thing, and this is using NMR. And with NMR, you use it just like a MRI machine, but instead of looking at densities, you actually can do different sizes and particles based on the methyl groups. So we can characterize chylomicron VLDL. And we do know from ultracentrifugation and other methods that the small dense LDL is very atherogenic, and in fact, small dense HDL is, but we just can't practically do ultracentrifugation. So with these different methods, we can separate subparticles and subclasses. And how is this useful? Well, suppose we have a patient come in, we have two patients, and they both have an LDL of 130. Ideally, might be about 100. So when we say, well, who needs to be more treatment? Do we need to do any treatment? And from many dozens and dozens of studies and with multiple methods, we have found out the patient with the smaller particles, which are probably more atherogenic, more oxidizable, have a higher risk than the ones with larger ones. In fact, drugs, statins can convert this over or decrease this. People with genetic disorders often have these. So what we can do with NMR is count the particle number, the size and the particle number. So the number itself, if it's greater than 1,000, you're going to have a big risk. And this patient over here would have a big risk. We could also look and see, does he have small or large particle, and that will help us to make him even a higher risk. There are multiple methods in the past we've done to look for this, but this is now a very practical way. And this is kind of what the numbers look like. They're very hard from a clinical standpoint. You know, how can I use that when someone says, does this patient need treatment? And one of the things we're doing here and developing here at NIH is a profile where we try to get kind of what the average one is. And when I look over here with HDL, this is small, medium, and large. This is increased. With here, small, medium, or small and large for LDL, this is increased. for the time being, I'm not going to go through triglycerides, use this just as an example. Well, what if I could further subclass this? And that's one of the things in the last just month or two we're starting to do. And if you look down here with the HDL, now I can further divide this small into very small and large, but they're both small. And in fact, this one is off the chart. This is genetically a very specific atherogenic particle. And even over here where the LDL was up here, when we subgroup, the smallest is the worst, most atherogenic, and it's off the wall. So this patient is not going to do. I also know ruminants are bad. So this guy has 3 strikes against him, and he has a genetic disorder, and we also need to treatment. So we can use it for 2 methods. And this is one of the things that we're actively doing here with our research. So now I'm going to go to, in about the next 30 minutes, to go over about 8 of the genetic disorders. So the very easy thing is where the truck is sending out its particles, it's going to the muscle, whatever's left is in the artery, and then this is reverse cholesterol transport. And for all you animal people, in humans, we have CETP, transfers cholesterol ester from here back over here. Animals don't. So there are some difference between animal models and humans. So this is the more one with apolipoproteins on them. They affect enzymes, they stimulate it, they tell the receptors where to go and things like that. But depending on where the defect is, I can look at their lipid profile and have a pretty good idea where the defect is. All 3 of these genetically will have a total cholesterol of 400. This one, the triglyceride will be 8,000, this one will be 400, and this one will be 1,000. That gives me a rough idea. So if I have a defect right here in either lipoprotein lipase, that's what clears triglyceride particles from the muscles. Its cofactor is C2. If I'm missing either one of those, I'll have a triglyceride of 8,000. I'll be unable to hydrolyze the triglyceride in the liver VLDL or the intestinal triglyceride. And in fact, if I draw the sample, set it down, and for about 5 minutes, it'll look like this. And I know my colleagues working with animal models, they have done it before. The same things. If you see this, this is lipemic serum. You don't even have to spin it. And that means that it's very high. Now, you could imagine as a clinician, if I would look in the back of the eye, if I could shine a light in and see a little arterial or something and flash the light, I may see the same thing. And in fact, I showed you lipemic plasma, and that's what we call lipemia retinalis. I'll show you a picture of it. It flashes up there. And you could imagine if all this triglyceride is around, it may deposit on the skin. And that's what we call eruptive xanthomas. And the outcome of very high triglycerides greater than 15,000 is pancreatitis. So pancreatitis will occur in a 2-year-old, in a 6-year-old, a 12-year-old, something that's life-threatening and certainly can kill them. These are the eruptive xanthomas that come out in crops. They're full of triglyceride. And I said I'd show you the back of the eye. So this is the optic disc. This is where we see most of our vision. And this is a normal artery. I shine the light, and sure enough, I'm seeing the lipid. I know the lipid is greater than 3,000 until I'm able to get those levels down. So that's lipemia retinalis. So the next question is, and I'm sure the answer is yes, do any of you work with ApoE knockout mice? I'm sure there are probably some, you may not even realize it, but it's the most common, I think, mouse on campus and used in research. And this is the human model of the ApoE knockout mice. And that's if you have a defect here, your cholesterol and triglyceride are going to be equal. So ApoE is an important used to clear in the receptors in the liver. Without that, your IDL particle builds up. And this is something between a high triglyceride and a low triglyceride particle. And this is highly oxidizable. We know that. We can pick it up on our NMR as a remnant particle. And it's very interesting because the human has what we call isoforms. So just like we have differences in eye color, hair color, ApoE with one cysteine is the most common. If you have a isoform, meaning one additional cysteine, that alters the structure where we think some of the additional apoproteins interfere, and you're unable to clear the LDL particle. Of note, if you get rid of a cysteine, this is the one that's associated with Alzheimer's. So you might have had a talk on that. So what do they get? They get xanthomas. And in some mouse models, you can see similar ones. And it's very classic. It's on the palm. Why do they have in the palm? We still don't know. So they can get palmar and eruptive xanthomas. And you can almost guarantee between age 30 and 40 they'll have a heart attack. But if you recognize it ahead of time, I can probably totally prevent it. So when you see someone with chest pain, as you're dialing 911, look at their palm. See if you can diagnose where their disorder is. So palmar, tuberous xanthomas, ApoE2, E2. So the last one that I'm going to show is a defect of the LDL, and that's the LDL receptor. There are actually many defects. You can have a ApoB, which binds. You can have an adapter protein, but there's more than 2,000 mutations, and this occurs in about 1 in 250 people in the US. So this is very important. And what they get is what appears to be amorphous and cholesterol deposition around their eye, which we call ARCUS. And before the age of 50, it's very significant that it's cholesterol. We don't still know how the cornea clears cholesterol. And they can get these other things called xanthelasma. It appears to be cholesterol inside the inner eye. And they can also get xanthomas. We call these tuberous xanthomas. A tuber is like a potato. You can pick these up, cut them right off. Nowadays, we have such good treatments, we are practically never seeing these in people anymore, unless they come in completely untreated. So these are tuberous. Then we have tendinous. They can occur right on the knuckles, and for some reason, they occur on the Achilles tendon. We don't know if it's an area of high friction. We still have no idea why they occur. So the other really worrisome thing is 1 in 250 are going to be untreated, have a heart attack in their 30s and 40s. So this is something that you'll have a strong family history of it, and with drugs is also generally preventable. So we've reviewed disorders that increase deposition to arteries, LDL, IDL, and what we call some remnant particles. But what removes the cholesterol? Well, this is another therapy, and this is kind of where a lot of our research is going, trying to remove it. So it doesn't matter how it gets there if you can remove it. So we've heard about how this is the truck getting rid of its triglyceride. For HDL, it's more of trying to get a taxi. I said we have to convert this nascent to cholesterol ester, and by doing that, this HDL now is destined to go back and potentially be secreted out by the liver. So there's the first two steps in what we'll call reverse cholesterol transport are very interesting. The free cholesterol is pumped out by an ABCA1 transporter. There's more than 50 of them. Multi-institutes are dealing with different ABC transporters. They tend to pump out bad things, whether it's chloride and cystic fibrosis to antibiotics to chemotherapy, all sorts of things. So they're very important. And in the body, it pumps out cholesterol. And this is an energy dependent. Then the second step, which is where my research is involved with, is converting this free cholesterol to cholesterol ester, which I said is this transferring an acyl group to cholesterol from lecithin. There have been no real treatments designed for this. Most of the treatments to raise the HDL are here or another thing of blocking it. That's why I think this is the right therapy. Animal models, all that seem to point that I think this will be the right therapy in the future. But here you're converting free cholesterol to cholesterol ester, and then the core cholesterol ester is going to be transferred actually back over. This doesn't occur in animals by cholesterol ester transfer protein. Out of the cholesterol coming out of here, 75% goes over here. The other 25% goes back as free cholesterol to probably SRB1. So reverse cholesterol transport and doing it the right way, where I think this is the rate limiting, is very important. So the defect in the first step is reverse cholesterol transport is ABCA1, Tangier disease. And I bet if I ask people here if they've heard of Tangier's disease or what it's named after, most people say, well, Tangier in Africa. Well, So this is the ABC one. In fact, there's an island in the middle of the Chesapeake Bay called Tangier Island. Here's the best way to get in. That's the runway for the airport. You don't want to overrun it. There are no cars, and it was settled in about the early 1600s by English. And the next time anyone came back to the island, they basically were either going to stay there or go over to Jamestown and winter it out and worry about Indians killing them. So there were about 5 or 6 families. They stayed there. And 1812 was the first time really anyone made contact. The British came up. They wintered over there with about 1,000 troops, went up and bombed Fort McHenry, lost, came back and said, "You want to come back to England with us?" They said no. And then really 1960 was the next time that really anyone was there. So if you go visit the island, they have the Shakespearean English accent. So they have it from the 1600s. If you don't understand it, the secretaries say, you got someone from a foreign country calling you. It's a very interesting dialect. Well, Don Fredrickson, one of our former directors of NIH, was the one who discovered Tangier, and he found them in the tonsils and the nerves. So you can kind of see, but the classic was orange tonsils. This is your mouth, that's your uvula and tongue, and they had orange tonsils. So this is one of the 2 probands. And the abnormal particles get into the spleen. They have no HDL, and it's a defect in ABCA1. Once again, it's a dimer, ABC transport. And very quickly, why don't they die at birth? Why don't they die at in utero? It happens to be we have a couple other transporters or exchangers that can exchange with lipoproteins, SRB1, ABCG1, and others. So you don't have HDL and you have those problems, which can be neurologic and low HDL and things, but you'll die of earlier heart disease, but not in utero or early at birth because of that. So the second step in reverse cholesterol is LCAT, the one where you free cholesterol to cholesterol ester, the one where you're forming the taxi, the one that's predisposed that I think is very important. Now, if you're missing this, an LCAT deficiency, this disk particle clumps up with other ones and forms a multilamellar particle, and we call that lipoprotein X. It's actually an aqueous core, and it clogs up the kidney. And when you initially clog up kidney, you spill protein. We call that proteinuria, and we have animal models where you can follow this. And then if you damage it enough, the proteins and things that are excreted, we call it blood urea, nitrogen, and creatinine, they then build up and end up needing dialysis and ultimately a kidney transplant, which recurs, unfortunately. So they also have the cornea and the red cells are very sensitive. So the red cells are the 4th biggest pool size of cholesterol in the body. So the cornea also has an intricate interaction with clearing, and HDL is very important. And I'll show you, they have the appearance of a fisheye, and they have this LPX particle. So this is what a fisheye looks like. It looks like if you're at the market, it's cloudy. In fact, this person has 20/20 vision, but if you shine a light at them or at night, they're glows and have problems. But eventually they can have problems also with that. And I said the red cells are important, so they get an anemia. And when the anemias mess up the membranes get very big, and we call these target cells. So you have an animal model, you think the membrane's messed up. I'm going to show you a couple examples where all you got to do is look at a blood smear and you may be able to tell something about, I know that the membrane on these are abnormal. And then I know they go from protein to renal failure to needing dialysis. So I'm just in 4 slides we just published a month ago our first in human treatment where we had recombinant human LCAT. And we gave it initially to get it on board to 4 different kindreds with low HDL and heart disease, and it raised it in all those. And then we did in 1 patient before we're doing the large one, enzyme replacement over 8 months. So we did a dose escalation, and then we had 2 maintenance phases. And this patient started with no HDL, never seen one. And we did 3 different doses, so this is over time. And eventually with the highest dose, we could maintain an HDL level. But also, HDL transfers with cholesterol ester over to LDL. We were also seeing it being transferred, doing its normal function in vivo. But if we really wanted to see the action of the enzyme, we'd want to look at the precursor and the product being cholesterol ester, free cholesterol to cholesterol ester. And to our happiness, even at the low dose, the baseline cholesterol was 18%. Even at the lower one, which wasn't really making the particle, it was making cholesterol ester, and a normal level is about right up here. And when you have cholesterol ester, you don't have LPX particles, and you don't get kidney disease. So one of our indirect methods was looking at phospholipid. Phospholipid went down threefold with the highest dose. That was the disappearance of the LPX particle. And I'll show you second the LCAT deficient patient, because this is a normal patient. This is VLDL. These are the different lipids on the left. This is LDL, and this is classic HDL and the precursor. Now, if you look up here, they have no HDL. They form normal HDL. This particle is part of that multilamellar phospholipid-rich LPX particle. It totally disappeared. In fact, this disappeared within an hour of the infusion. So we had very good evidence. We now had HDL and we had no LPX. And we also progressively over 8 months, this is the infusion, it would go up and we could stair step it when we could keep it 1 week. It would go down a little bit when we went 2 weeks. But we maintained the increased cholesterol esters. And this is a little complex, but this is the one where we stabilized or improved the renal. The orange is creatinine, one of the functions we went down here. Unfortunately, the patient had another genetic disorder for rapid heart rate, AFib, and had to be put on amiodarone, which is known to increase creatinine. So that went up, but his BUN maintained, stabilized, or actually was reduced some, and another real sensitive cystatin maintained. So this patient was a week away from needing dialysis. He already had his fistula and everything. So we knew we could maintain it, but we weren't, we knew once the kidney's damaged, we're not going to reverse it. So we need to get people early on, treat beforehand, or when they're going for kidney transplant to prevent the rejection. And we also showed that there was, in about 6 weeks, about a 25% increase in the hemoglobin. We also found out that when you go to the ICU, they draw a lot of blood. So that was just multiple blood sticks. So it was well tolerated. We saw improvements of renal and hematologic, and we're hoping within a year or two we can, it's been bought by a major pharmaceutical company, and they're actually going to devise it for raising HDL and heart disease, kind of a rotor-rooter. But we're going to be able to parallel on with that and hopefully do the rare disease patients and cure them of their renal disease or prevent it. So in the next couple minutes, I'm going to do 2 of the classic intestinal liver disorders that lead to lipid disorders. And the first one is A-beta lipoproteinemia. And these patients basically are the ones without cholesterol. They have no triglyceride, and they have a defect where if you eat fat in the diet, you basically, it will get into the enterocyte, but you cannot absorb that triglyceride. And if you can't absorb that triglyceride, you can't absorb fat-soluble vitamins. So it's not really not getting cholesterol in because the body can make it. It's not getting in vitamin E and vitamin A, and I'll show you those clinical findings, which, in animal models, other things potentially could be used. And the liver itself cannot secrete. So there is none of these triglyceride particles. There's none of these triglyceride particles, and the only thing they have is in reverse cholesterol transport. So they get fat malabsorption. They could not eat a cookie. They wouldn't know what a potato chip was because if they got it, they'd get bloating and diarrhea. And I'll show you the neurologic. They get a very specific spinal cerebellar. Well, what's that? That's vitamin E deficiency. Well, what's spinal cerebellar? Proprioception. When you moving the hand, knowing where it is called proprioception. Vibration. Why, you wondered why doctors have those tuning forks. Vibration is one, and deep tendon reflexes. So they get very clumsy when they start early vitamin E deficiency, but it's not a muscle ache, it's not weakness, things like that. But that's purely due to vitamin E. And then when you're not having vitamin A, taking your multivitamin or whatever, they get an abnormal deposition in the back of their central vision. First thing that goes is night vision, and then they lose their vision entirely. And then, once again, we said the red cells are very important. If we don't have a pool exchanging with it, they're going to have what's called acanthocyte. And it goes back to acantha is Greek for spine. It's going to have a messed up lipid. Once again, you can see that in animal models too. So they're missing microsomal triglyceride transfer protein. So this is back to our basic science. This is a ribosome in the liver or the intestine. You're making ApoB. MTP is a dimer, and it incorporates lipid into ApoB. As it goes along, you get what's, in this case, VLDL, and this is where vitamin E and A slip along just for the ride. So the biggest problem, there is no other transporter really for these, and that's where they get the neurologic. So if you look in here, the only normal cell is here. So once again, the membranes are messed up. Without the lipoproteins, red cells membrane gets messed up. This is an intestinal cell. All this patient had was one Oreo cookie the day before, and you can have your microvilli folded up. But all this stuff here, and all this is their Oreo cookie. These are a couple normal goblet cells, but otherwise it looks perfectly nice. But it can get in there, but then it goes back out. It gets sloughed off. So, and it actually can look orange if you do endoscopy on them, but it's not physiologically affects the enterocyte itself. And the neurologic degeneration, I said spinal cerebellar ataxia. Ataxia is balance, and that's basically vitamin E deficiency. So we're giving them incredible doses. We give them where recommended daily is 1 tablet. They're getting 12 tablets 3 times a day, and we're just barely getting enough in. The vitamin A, this is the optic nerve where the vessels and nerves come out. This is where our central vision is. They get deposition of part of probably, we're not really sure what it is, but basically you can't see central vision and they become functionally blind. So that's the first one, and this is the second one. This is the one that Wynn was talking about, cytostrolemia. And I think this is interesting from a genetic aspect, but this is also interesting from when you go to the store tonight or over the weekend. You're going to find out you are part of the cytostrol experiment. So basically, there's a defect in the intestine, and there's basically there's a defect in the liver. And for some reason, the human body decided the only sterol they want is animal cholesterol. There are numerous other sterols, as Wynn was saying, but for some reason, these either are very oxidizable, they cause inflammation or things like that. So the body has decided it wants an ABC transporter, and it has designed an ABC G5 and G8. So where do we have our cholesterol? Well, what do you think about it? In a yolk of an egg. Where do plants have most of their cytosterol? In the seeds. So you're going to do fine with the lettuce, but if you eat the lettuce seeds or the sesame seeds or the peanuts, those are going to be high in cytosterol and compestrol. And with our patients with cytostrolemia who have the defect, they know in the spring they go out and garden, they eat all these fresh vegetables, they think they're doing great. Their xantholasmas get bigger, their xanthomas, so they know it. They know which foods, but basically animals, plants behave pretty much the same. This is the cholesterol, and the only defect between the plant and animal is in the 24 position. If you have 1 carbon, it's campestrol. If you have 2 carbons, it's cytosterol. If you're an algae, you put 2, you're brassicasterol. So there are numerous ones, but the body does not want anything other than cholesterol. So 1 carbon, 2 carbons. So why can't we just measure these? Well, when you go to clinical chemistry, they measure cholesterol by putting a color group on this hydroxyl group. So we can't really differentiate them. You got to use HPLC or GC. So they look like familial hypercholesterolemia, ARCUS, tendon xanthomas, but the one thing in my mind is generally they have arthritis. And it's a defect here. So it's a dimer. And we know cholesterol, this is the enterocyte. We have a sterol pump, which is NPC1L1, which is not Niemann-Pick, but it got named for that. And it allows any sterol in, and then G5 and G8 pumps out any other sterol other than cholesterol. So in the case of cytosterolemia, they pump it in and they don't have this. So this gets into the body, it's very oxidizable, it causes arthritis, things like that. So one of the interesting things is we said, well, what if we could target this? And there is a drug, ezetimibe, Zetia, that will target this. And sure enough, you can really very effectively decrease the amount of cytosterol getting into the body of these patients. So what does cytosterol or cytostenol have to do with you all? Well, normally when you're absorbing food, you'll have pancreatic enzyme, which will have cholesterol, triglyceride in what are called micelles. This is how we absorb it. And typically in our diet, we have a lot of cholesterol from bile, and there's not that much cytosterol. So they're competing one for one. Any cytosterol gets pumped out. So what did someone think? Well, what if we enhanced the diet with cytosterol, such as Binacol? Binacol is 100%, it's a margarine, 100% cytosterol. And in that case, one for one, so more cholesterol is malabsorbed. But it's only of the order of 2 to 8%. But it's enough for them to make you increase the cost of your foods probably 25%. So what do? They put it in Binacol, is pure. If you look in the butter, it's always on the right side. It's 100% cytosterol. Promise Active, why is it helping you? Why can they say actively removes cholesterol? It's the cytosterol. How about Minute Maid, reduces cholesterol? It's that vitamin? No, it's cytosterol. Even in cheese, in bread, in healthy heart, keeps your cholesterol low. You know, all this is because all they have to do is say it's a supplement and it lowers it 2 to 8%. So, but you're going to pay 25% more probably. So, but it's all over the markets. So, and it's even in the pharmacy. You're going to see Cholestoff, Cardio-Colot, and you say, ooh, that must be something good. Well, you're just getting a little plant. You become a vegetarian. So I'm going to probably end it on one last genetic one, which I think is very important, and not talk like anyone, but anyone in the lipid field know what the current $15,000 question is? And that's the PCSK9 inhibitor. We have sat and argued about statins being too expensive at $1,200 or $1,500 a year. There's now 2 PCSK9 inhibitors, and I'm going to tell you what they are, and they're either $15,000 or you can get a bargain at $14,500. So it will double or triple our health insurance pharmacy if everyone who would like to be this on them is on them. So basically what it does is when LDL is cleared, and we know the basic physiology, the thing that regulates LDL receptor is this PCSK9. So its job is co-secreted. So where someone might have an LDL of 90 and someone has 200 or 130, if it's not a genetic cause, insulin, triglyceride, diet, SREBP, all those are affecting the SRB1 that then feeds upon the LDL receptor. So it ends up, this was found in a genetic study, which I don't really have time to tell about, but it ends up, if you're mutated up here, you get a gain in function, meaning it works too well and it destroys the LDL receptor and you have high LDL. In this case, you have a loss of function. It destroys it and you have low LDL. And actually, genetically, you do better than any drug that is possibly done. But as a result of this, the pharmaceutical company noticed that, okay, you get LDL receptors, they get in the clathrin pit, LDL comes, you recycle it, and this keeps going 100, 150 times. But at the same time, PCSK9, which is regulated by anything you could think of, everyone in this field has something that regulates it. And what it does is it determines what your LDL value ultimately will be because it destroys the LDL receptor after 75 times or after 110 times. So the company said, well, what if we can do something to this? and that's where they developed monoclonal antibodies. And the monoclonal antibodies destroy this, and it allows your LDL now to have more LDL receptors, and your cholesterol goes down another 60 to 70%. So we can get LDL values down to 40, 30, 20 pretty easily with these PCSK9s. Now, we don't know the long-term effect of getting a monoclonal antibody injected every 2 weeks. We probably know the long-term effect of a $15,000 a year drug. It's going to be very expensive. But I can tell you there are people on campus working with people I collaborate who are developing a vaccine, which you may be able to take once a year. There's antisense. There's small molecules people are trying to do. Anyone who can make it cheaper will definitely be the next replacement for statins. So these are the two. It's price, it's the biggest thing. So I'm going to finish in about 2 minutes. I think, well, I'll go for about 5 more minutes. I have 3 slides on therapies. And this will kind of transition into Denny, who's going to be talking about a couple disorders where they're doing large clinical trials. I'm not going to talk any about those here. But we've talked about where the triglyceride goes down to VLDL, and we have statins, which are on the market. This is Zetia, cholesterol absorption inhibitors, bile acid resins. They all increase the amount of LDL receptors. We also just talked about PCSK9 that either inhibit or prevent the degradation of LDL receptors. So we have PCSK9s. We also have approved, but only for the highest of the highest cholesterol, ApoB. We mentioned ApoB is what's on the triglyceride particle. There's an antisense that will degrade ApoB. There's also MTP. Wait, that's a disorder in A-beta lipoproteinemia. That's what allows it to secrete. They have an inhibitor of MTP. Well, all these, what do they have to worry about? Fatty liver. Fatty liver could be a complication of these because A-betas have fatty liver. So safety is potentially a factor here. I'm also showing here, we now went back to the VLDL, to the triglyceride particle. This is the triglyceride particle. And the only thing I really mentioned was lipoprotein lipase, or C2. If you miss either one of these, your triglyceride is 8,000. Well, over the last 2 to 3 years, they've discovered that ApoA5 stimulates that. They found if it's missing in the Amish, it lowered their triglyceride. And ApoC2, as an antisense, has been tried and published, New England Journal. It is an inhibitor, it's an inhibitor. So there's also, New England Journal, the last 2 months, this angiopoietin-like 3, 4, and in fact, I have to add 8, all having effect on lipoprotein lipase. These are all affected by insulin, fatty liver, adipocytes, triglycerides, you name it. So this has suddenly become a very complex thing because if these particles are not completely metabolized, we call them remnant particles, they probably account for a lot of the atherosclerosis we can't account for. And this last one, I'm not going to go through, but you'll see it. It goes everything from transcription to post-transcriptional to translation to protein targeting. They're approved adeno-associated viruses for lipoprotein lipase. It's about $750,000, but it's approved in Europe. We've heard about CRISPR and how that may come into evolve. This is the one that I mentioned was involved with antisense for ApoB. ApoC3, there's studies going on in the clinical center right now with that. And there's also other of these attacking the single-stranded DNA with apo-a, this angiopoietin-like, and other things. The PCSK9, there is an antisense. It may be too expensive, but there are also enzyme replacements. This one for cholesterol ester storage disease. Recombinant proteins, that's the one that we're developing here at the NIH. There's mimetics. Rather than spend on the whole protein, use an A1. They don't even have A1. ApoE is useful. ApoC2 is useful, one developing here at the NIH. Then this mentions the PCSK9 inhibitors, the MTP inhibitor, PPAR, on and on. So I think I'll kind of wrap it up with that, but I think I would like to say where, I could not work with translational medicine without interacting very closely with the basic science people and all that. And in the theme for Wynn, I'm going to end with my bridge talk. However, I don't think he showed you some of the details. If you look really careful, there's a clinical researcher right over here, and there's a basic science. And actually, they're working very careful. But as I think most of the people in the audience know, it's really the postdocs and the fellows out here that are probably getting a lot of that done. And if you look carefully, I think there's a few summer students way out there. But I think, as I would end, my acknowledgments are for the bridge makers. We can't really successfully do that. And I am only going to show the few people who were involved in just our recombinant enzyme one. There's many people I've left out of here, and I have not put any of my NIH collaborators, who there are many. So with that, I think I'll turn it over to Denny, and we're going to switch to intracellular cholesterol disorders.
Well, that was magnificent, Bob. We have some time if you have some questions to ask at this point. So let me ask you a quick question here. Given this expanded playing field with many opportunities to interact pharmacologically, antibodies and so forth at different points, so what then becomes the role of diet and exercise?
I think that's a very tough question, but the way I kind of give it to my patients is I tell them, because I'm a metabolism person, to think of it as like your sink. If the sink is filling up, there's several ways that it's filling up. One is the water's coming in. That's synthesis, and many times those are genetic disorders, and we got to inhibit that. The other is it's clogged and things like that. But then I say, if it's filled up, what happens if you come and then pour a bucket of water in there? You're going to increase it. So I kind of tell them there's probably 25% of the population who genetically have it perfect, and they can eat a dozen eggs a day. They will not have a cholesterol, and I think there's some famous papers where people have shown that. Then there's the 25% who clearly have delayed catabolism or something where I think it'll have a major effect. And then the other 50% are somewhere in between, depending on their exercise. So we probably make public guidelines for that 25%. But if we had a way, maybe, there are some people who don't, and there have been good questions of what evidence do we have for cholesterol in the diet? Well, some of the old ones, even that we question, we should even question whether or not we should use them at all. But, it's one of those tough questions where diet affects a smaller group, but it's very difficult to tell which group that's going to have an effect on.
So let me ask one more.
Mm-hmm.
So this is the NIH, and you're in a position to look at all of these parameters.
Mm-hmm.
You're in collaboration with
Mm-hmm.
people. So now you're the patient who is seeing a competent internist someplace who doesn't have access to all this, and yet the patient has a cholesterol of close to 200 or 200 and something. And, what's the current status of medicine with regard to dealing with that patient? I mean, they're all told to exercise and don't eat so much, but it doesn't do very much usually.
Yeah. It's chaotic, schizophrenic, and very mixed up because, I think the thing is we have guidelines that are confusing and things like that. People would like to make it easy. It's getting so complex. When you say that, there's like 70 million people who probably would like to get in the NIH, but Denny and I, we just can't see that many, So, I think one of the things is we try to make guidelines which are easy for a practitioner, and the current ones have slid to one side where you say, you just give this dose and you really don't do that much follow-up. But For that other 25%, they probably need to see what that effect is. Rather than saying, give a statin where we know that there's a 50%, people need a little encouragement and look and say, you're only at 30%. And then they're going to say, well, I've really not been taking my medicines, I haven't been exercising, other things, when you should get that 50%. So, I think we need something where we kind of check up on them. And if we don't get 50% and they've had a heart attack, we probably need guidelines that then say we do need some of those additional medicines. And the current guidelines almost arbitrarily said any study that's more than 10 years old, we're just going to throw out because it couldn't have been good. So, and that leaves all the niacin, the fibrates, the bile acid resins, which were small, but when you look back at some of the bile acid resins in ones, they showed angiographic changes in 500 people. We're not seeing changes in 20,000 patients because they're so quickly rushing through these studies with, questionable endpoints. So, I think we're kind of forgetting our past where people need encouragement. They need to know that science is reliable, and they do need some checking up on, I think, for motivation.
But right now, the statins
I still
cheap
think
and available.
They're cheap and available. Crestar is going generic now, so they're all going to be generic. So, not quite putting them in the water, but, it's for the appropriate patient, I think it's, from a public health standpoint, the best medicine.
But the appropriate patient is the one in whom it works.
Right, yeah.
So
but it's,
that.
Many studies are trying to look at healthy people and say, can we get better than healthy? Well,
yeah.
I don't think you can, so.
Okay, thank you very, very much. That was marvelous. And so, Danny, would you continue, and we'll have questions afterwards.
Okay, what I'd like to talk about this evening is disorders of cholesterol homeostasis, and I probably should have renamed this and been a little bit more specific. So I'm going to talk about disorders of intracellular cholesterol homeostasis in contrast to the sort of extracellular and the plasma homeostasis. The two disorders that I'm going to talk about today are Smith-Lemli-Opitz syndrome and Niemann-Pick disease type C. Both of these are autosomal recessive genetic disorders. Smith-Lemli-Opitz syndrome is a multiple malformation cognitive impairment syndrome. In contrast, Niemann-Pick disease type C is a lethal neurodegenerative disorder. SLOS, or Smith-Lemli-Opitz syndrome, is an inborn error of cholesterol synthesis and has an incidence on the order of 1 in 40,000, and there's no approved therapies. NPC is a lysosomal storage disease in which there's accumulation of unesterified, or as referred to, free cholesterol. It's rare with an incidence on the order of 1 in 100,000, and again, there's no approved therapies. So in my research group, our main goal is try to combine basic and clinical research to develop and test various therapeutic interventions. So I'm going to go through these two disorders, and I'll start with Smith-Lemli-Opitz syndrome, or SLOS. And as I mentioned, this is an inborn error of cholesterol synthesis. It has a very broad phenotypic spectrum, and this is characteristic of a lot of these autosomal recessive disorders. They're sort of the classical disease that got described, but as people figure out how to diagnose these disorders, you end up getting the variations, the more severe cases and the milder cases. So it ranges from a very severe disorder, and those infants often die prior to birth or soon after birth due to complications of multiple major malformations, to a mild disorder that combines minor physical findings with neurocognitive problems, learning and behavioral problems. And on this slide, I'm just showing some of the typical craniofacial features. They frequently have microcephaly or a small head. They'll have drooping of the eyelids, which is known as ptosis. They frequently have this small upturned nose, so you're looking right into their nostrils in these kids. And they have frequently have small jaw. They don't have cleft lip, but cleft palate is frequent. Many of the kids more severely affected will have postaxial. So on the side of the hand with the small finger or the small toe, this postaxial side, polydactyly, or an extra finger or toe. More severely affected children can have ambiguous genitalia. This is a male child, and as you can see, has ambiguous genitalia. And then the most common physical finding in Smith-Lemli-Opitz syndrome is this 2-3 toe syndactyly. Now, don't panic. Somebody in this room may actually have 2-3 toe syndactyly. It doesn't mean you have Smith-Lemli-Opitz syndrome. That's a normal variant. It's just it's very common in Smith-Lemli-Opitz syndrome. In addition to the physical manifestations, Smith-Lemli-Opitz syndrome has a behavioral phenotype. These babies are really hard to care for. They're irritable, they have a poor suck, and a lack of interest in feeding. They could care less. They have tactile defensiveness, so they're irritable, sitting there crying, won't eat, and they don't want to be picked up. And if you can imagine trying to take care of a baby as a mother or a father that doesn't want to feed, doesn't want to be picked up, and sits there and cries all the time, it's really rough on the parents. Older children have autistic and obsessive compulsive traits. They show language impairment, self-injurious behavior, abnormal sleep patterns, hyperactivity, and then sensory hyperreactivity. Try clipping their nails and they go through the roof. Combing their hair, they could go through the roof. So it's a very interesting behavioral phenotype. A lot of it related to food intake. One child would eat apples. That's what she would eat. Had to be in a specific bowl, had to be peeled, and had to be gala apples. That's how specific it was. Okay, as an inborn error of cholesterol synthesis, Smith-Lemli-Opitz syndrome is due to a deficiency of this enzyme, DHCR7, or 7-dehydrocholesterol reductase. 7-dehydrocholesterol reductase reduces the delta-7 bond in 7-dehydrocholesterol to yield cholesterol really in the last step of the cholesterol synthetic pathway. So in Smith-Lemli-Opitz syndrome, you have a block here. Cholesterol in general is deficient, but you have an accumulation of 7-dehydrocholesterol and then accumulation of this isomer 8-dehydrocholesterol. So dehydrocholesterol accumulates and cholesterol is deficient. Just to put it into the context of the cholesterol synthetic pathway, this is Smith-Lemli-Opitz syndrome at the last step here. This is just the last half of the cholesterol synthetic pathway, what I refer to as the post-squalene cholesterol biosynthetic pathway. It's after you've formed sort of the cholesterol ring. Smith-Lemli-Opitz syndrome was the first defect to be demonstrated in this pathway. But since that time, a number of other genetic syndromes have been shown to be due to different steps in this pathway. I'm not going to go into those today, but just they tend to be more rare than SLOS. So one of the questions we have is, you have this defect in cholesterol synthesis. Why do you end up with this dramatic developmental syndrome? And this relates to the fact cholesterol actually is important. If you have too much, it obviously causes problems. But if you don't have enough, there's normal cellular processes that require cholesterol. And it's an essential component of cellular membranes. It's a major component of myelin. It's a major component in what are known as lipid rafts. This is where many signaling molecules are concentrated in the plasma membrane. It's essential for embryonic development, in particular in hedgehog signaling. And then it's a precursor for a lot of other compounds that are essential. Steroid hormones and neuroactive steroids, oxysterols, and bile acids. So if you have a cholesterol deficiency, you could say, well, you have a deficiency of these normal cellular processes, and that would explain why you have a defect in SLOS. But it turns out that 7-dehydrocholesterol, although it's different than cholesterol, actually enters these various biological pathways to a certain degree. So in SLOS, you have a question whether it's due to the deficiency of cholesterol or whether it is a toxic effect of the 7-dehydrocholesterol itself. So that's really a major question that we're often trying to ask. What's the biochemical basis of Smith-Lemli-Opitz syndrome? Is it the cholesterol deficiency or the 7-dehydrocholesterol toxicity? Now, the answer probably is it depends. It depends at what you're looking at. There are biological processes that it's probably the cholesterol deficiency, but my bias is that there's a lot of biological processes whether it's actually 7-dehydrocholesterol toxicity. And I'm just going to give you an example from the lab of a model system in which we looked at whether it's a defect of cholesterol or due to toxicity of 7-dehydrocholesterol. And what these are induced pluripotent stem cells that we derived from our patients. And what we found, this is a control line, this is an SLOS line. And you can induce the formation of these pluripotent stem cells. They look normal if you maintain them in media with cholesterol, because the cells just take it up from their environment. They have no need to make cholesterol, therefore they don't make 7-dehydrocholesterol. If you switch them into a low cholesterol media, the control cells are just fine. They continue to express the markers of undifferentiated markers such as NANOG, and they don't express differentiation markers such as PAC6. But the SLOS iPS cell lines rapidly undergo differentiation towards neuronal lineages. They lose the pluripotent marker NANOG, and they start to express the neuronal precursor marker PAC6. And so this is an interesting process, sort of suggests when you induce the biochemical defect, you get this precocious neuronal differentiation. And we wanted to separate, well, is that because now we made the cells cholesterol deficient because they can't make the cholesterol, or is it due to the accumulation of 7-dehydrocholesterol? So we made an iPS cell from another patient that we have who has one of these other defects in cholesterol synthesis. They have what's called lithosterolosis. They have a defect in the conversion of lithosterol to 7-dehydrocholesterol. Now, SLOS is rare. Lithosterolosis is very rare. I think there's about 5 patients in the world described with it. But we've seen a couple of these. We diagnosed a couple of these patients, and we have iPS. We're able to make iPS cell lines from these patients. And using the same paradigm, this is the cell line in a cholesterol replete culture, maintains pluripotency. And if you deplete cholesterol, it maintains pluripotency, really suggesting that it was the 7-dehydrocholesterol that was the bad actor in this particular situation. And this is sort of a summary slide from a lot of work that we did. It actually, to try to say, why? What is happening? What's the 7-dehydrocholesterol doing? And what we found was that there's actually, it turns out to try to maintain the pluripotency, you want to maintain Wnt beta-catenin signaling. And in the SLOS cells, when you switched them to cholesterol-free media, you lost normal Wnt beta-catenin signaling. And it turns out that cholesterol is essential for the stabilization of the Wnt receptor complex. And when you put in 7-dehydrocholesterol, you actually destabilize that receptor complex. So the 7-dehydrocholesterol really is acting in a toxic manner to disrupt the Wnt signaling complex, and thus you get the precocious differentiation of the neurons. We also think that this probably is applicable clinically in that the dehydrocholesterol may be the bad actor. And what this is a correlation of cerebral spinal fluid sterols with neurocognitive measures. In this case, we're looking at measures related to the ADIR, or a typical autism diagnostic interview score. And what you can see is that the there's a better correlation with the dehydrocolesterols and various aspects of the ADIR than there is with cholesterol. Again, suggesting that the 7-dehydro, it's only correlative, but suggesting that the 7-dehydrocholesterol with this aspect of the phenotype may be the bad actor. So this really is, in my mind, the fundamental question that we have to ask when we're thinking about treating SLOS. And that's really, to what extent are the mental and behavioral problems in SLOS due to fixed developmental abnormalities versus to what extent are they due to the functional problems secondary to the abnormal sterol composition in the CSF. Okay, to use another analogy, if this is an electrical system and it's miswired, we're not going to be able to fix it. If it's an electrical system and there's corrosion at the contact points, you can correct that corrosion. And I think in the classical to mild kids, we probably have a component of the behavioral problems that can be addressed by correcting the biochemistry in the central nervous system. Okay, and this is an old slide, but it gives a sense that perhaps we can reverse the defect in neurons. And we had shown in a number of studies that, in SLOS neurons, there was a defect in neuronal transmission, in particular with glutamate receptors. And we started up another collaboration, and this was an in vitro study, and the collaborator called me up and said, Denny, I think your initial studies were wrong. We did the experiment, and there's no difference between the control cells and the SLOS neurons. Like, okay, what's going on? You never like to hear that your initial study might be wrong. And we went over what they did, and it turned out while they were processing the neurons, there was a single step in which they used a media that contained cholesterol. We corrected that, and then we could restore the defect. So it gave you the sense that a single exposure to cholesterol would actually correct, at least in vitro in this study, correct the neurological defect. So we've been working in the clinic to try to see if we can develop a therapy for SLOS. And if you have a deficiency of cholesterol, we all know how to fix that. You can figure out where to get cholesterol pretty easily. What was tried was dietary cholesterol supplementation. And there were multiple case reports out there of efficacy. Oh, the behavior got better. You know, the kids are doing better. And I absolutely agree. The kids are probably healthier. But it's hard to explain behavioral improvement because cholesterol doesn't cross the blood-brain barrier. With regards to cholesterol metabolism, the brain is on its own. It has to make its own cholesterol. So we said, well, okay, let's look at this. Let's set up a randomized placebo-controlled double-blind crossover trial and really answer the question, does dietary cholesterol do anything? Because it'd actually be important to know. I can think of other mechanisms. It might be neuroactive steroids crossing into the central nervous system. And if you knew the mechanism, you could really try to target the therapy. So we used pasteurized egg yolk versus egg substitute. Because cholesterol dietary supplementation had gotten entrenched in the field, it was going to be impossible to get parents to take the kids off of cholesterol for any prolonged period of time. So we said, fine, we'll do 2 weeks treated versus untreated. Because what was described in the literature was really rapid. You put them on cholesterol, it corrects. If you run out of cholesterol, their behavior goes off. We said, okay, we'll try 2 weeks. Well, and we were using the hyperactivity subscale of the ABI checklist. Really underpowered study. It's hard to do a study when everybody is convinced that it works. Dr. Porter, why are you doing this? We already know it works. How? Well, we know it works. After 3 years, we got a little bit frustrated. We had enrolled 10 of 40 subjects. Said, enough's enough. I mean, I'm not going to get this completed in my lifespan. And we broke the blind, stopped the study, broke the blind. Have never had this happen. On the primary outcome measure, p-value of 1.0. we need to do placebo-controlled studies if we want to understand things work and not just accept the fact that they work. Just trying to do things is comforting, and parents will think that they work. Okay, a little better, we tried a simvastatin study. So what was the rationale here? Simvastatin is one of these HMG-CoA, is an HMG-CoA reductase inhibitor, a statin drug that we heard about earlier. And the rationale here was, well, maybe 7-dehydrocholesterol is toxic, so you could actually decrease the production of 7-dehydrocholesterol by inhibiting cholesterol synthesis at an earlier step. We also added to that hypothesis in that we proposed that you also might get a benefit because you would increase expression of DHCR7 alleles with residual enzymatic function. The kids with mild Smith-Lemli-Opitz syndrome aren't completely absent, don't have an absence of the enzyme, they just don't have enough enzyme. And when you give somebody a statin drug, it was well known in the literature that they actually upregulate to try to get around the block, and these enzymes are coordinately regulated by SRIB2. So if you try to upregulate HMG-CoA reductase, you also upregulate DHCR7. And the idea was, okay, if you have an enzyme that works at 5%, maybe doubling it to 10% might do better. And at least in vitro, we could show that simvastatin would upregulate DHCR7. And in cell culture, we could actually show we could increase and improve the cholesterol total sterol ratio by treating the cells with a statin. Now, it's a two-edged sword. Once you get to a high enough dose, you start shutting down cholesterol synthesis, and 7-dehydrocholesterol is better than nothing. So we moved forward with a placebo-controlled trial. We used a crossover design. And a crossover design is where a single child starts out on either placebo or simvastatin, and then halfway through you do a crossover. And the advantage of this design in a rare disease that has a heterogeneous phenotype is you can use the child as their own control. So it's not a two-arm study where you have to get numbers high enough and try to match the two groups. In this case, both groups are matched because it's a crossover study. Okay, we enrolled 23 patients and had 18 patients complete the study, which was our goal. And we were able to show that we were able to actually decrease dehydrocholesterol total sterol ratios. So we decreased dehydrocholesterol levels consistent with the hypothesis of what would happen biochemically. But also when we looked at our primary outcome measure, behavioral outcome measure, and in this case we were using the irritability subscale, we could actually see that we had a decrease in the simvastatin treated group versus the placebo treated group. So this was the first controlled trial demonstrating the potential of drug therapy to alter sterol composition and actually improve SLOS behavior. So going to switch gears here to the second disorder, and this is NPC1. NPC1, as I mentioned earlier, it's an autosomal recessive progressive lethal neurodegenerative disorder due to mutation of either NPC1 or NPC2. When cells take up cholesterol, they take it up as LDL cholesterol, which we heard earlier. The cells internalize it, and it moves into the endolysosomal system. And in LDL, cholesterol is present as LDL, as cholesterol esters. Acid lipase removes the fatty acid, giving you the free or unesterified cholesterol. NPC2 and then NPC1 coordinately work together then to move the cholesterol across the glycocalyx of the endolysosomal system and to make it bioavailable to the rest of the cell. So if you're minus either NPC2 or NPC1, you have a block here and you get an accumulation of the unesterified or free cholesterol. And this is shown in this slide. This is a fibroblast stained with a drug called filipin. It's a fluorescent antibiotic that binds to unesterified cholesterol. And you can see that these NPC1 cells accumulate unesterified cholesterol, and if you look at what those organelles are, they're in the endolysosomal system. Its incidence is on the order of 1 in 100,000, although we did a screen through some of these large whole exome sequencing databases, and there may be a late onset variant that's much more frequent because there are some alleles that look to be detrimental that are actually present at high frequency, and that's still to be characterized further. But the classical disease is on the order of 1 in 100,000. Okay, so what are the therapeutic trial issues that we're dealing with? And I put this in the NPC part, but it's also true of SLOS. It's a rare disease. We have a heterogeneous phenotype. So in NPC, we're dealing with a variable age of onset and also a variable symptom complex. And then clinical progression occurs over years. So if you think about this from a statistical standpoint, we're dealing with a small n, a large standard deviation, and a small delta. It doesn't get any worse. It's what makes clinical trials hard in rare diseases. Our goal is also to stabilize or delay neurological disease. If we've lost the neurons, we're not talking about methods currently to replace the neurons, cellular therapies where we're actually going to replace neurons. So we're actually looking just to stabilize it and to stop it where it is presently or slow it down. And one of the issues that we have is that there was a lack of defined and accepted outcome measures. And outcome measures are essential. If you do a clinical trial, how do you know it works? Some of the outcome measures I showed you earlier with SLOS were using the aberrant behavioral checklist, some neurocognitive measures. We didn't necessarily have the equivalent in NPC when we started. So how do you try to address that problem? And with all of these rare disorders, it's essential that you do natural history trials. You really need to understand the disorder in order to understand whether, if you have a therapy, it works or not. And it's really too late to start trying to understand the disorder when you have a potential therapy in hand. So it's best to start it as soon as possible. We started seeing patients here in 2006, and since that time we've seen 93 patients with NPC. Our age range is 3 months to 54 years of age. We're biased to the pediatric age group, the more classical disease. And I'll touch base on this NPC neurological severity score that we developed because I'll come back to it later. And our goals were to identify clinical or biochemical markers that could be used as outcome measures in a therapeutic trial. And then also to identify a biochemical marker that could be used for diagnostic testing or screening. And the reason for that is in our cohort of patients, our diagnostic delay was 4 to 5 years. What's that? From the point of time where a parent is saying something is wrong with my child to getting a diagnosis was 4 to 5 years. That's because it's an insidious disease, slow onset. Sometimes it's hard to pick out, oh, your child's fine. They're just a little bit delayed. So it took 4 to 5 years, and it ranged up to 19 years for one family to get a diagnosis. And contributing to that, sorry, I got ahead of myself, so I'll come back to that. Let me discuss this NPC neurological severity score that I talked about. We needed a method to try to describe the patients and describe the phenotypic heterogeneity. All the patients were different, so how do you describe one patient and try to describe, one patient has this symptom complex and progressing, and this patient has this symptom complex and is progressing. So how do you try to put it together to get an overall gestalt about how different patients are progressing? And this scale included 9 major domains, 8 minor domains. It's a Likert-like scale. What does that mean? It basically increases from normal to here with ambulation to wheelchair dependent in sort of incremental amounts. So a higher score is related to increased physical impairment. We can use this retrospective and prospective. This is an example of a retrospective study that we did here. It turned out that NPC was studied at the NIH in NINDS in the 1990s. In fact, Peter Penchef was here and was responsible for identifying the biochemical defect of the intracellular accumulation of unesterified cholesterol. So we were actually able to go back to those records and from those records reconstruct the disease progression over 5, 10, 15 years, which was a huge advantage because if you're starting de novo, you'd take 15 years. But here we could use the medical records. So a plug out there for any clinical fellows. Good records are valuable, especially in these rare diseases. You really can't do much with, lungs clear to auscultation, not much other, and same as before. But with good records, we were able to construct, and we can see how patients progressed over years. And using progression modeling, we can predict that patients progress at about 2 points per year on this particular scale. Okay, coming back to the diagnostic delay. One of the things contributing to the diagnostic delay was the difficulty in making this diagnosis. There was not a blood test. The classical way of making the diagnosis was this Philippine staining of fibroblasts, and I showed you that picture early on. But to get fibroblasts, you have to do a skin biopsy. And there's a high activation energy to people doing a skin biopsy. Okay, it's much easier to draw blood, send it to the lab, and you don't have to worry about it. You do skin biopsy, you have to send it to the lab, they have to grow up the cells, and you have to send it off to a reference laboratory to run the test. And it turns out there's really only 2 laboratories in this country that run the Philippine staining test and do it well. There's some tests in Europe that do it very well too. So it was very specialized testing, required the skin biopsy, and people just, oh, we'll test for all these other things. So lots of kids came in, and yeah, you look at their records, and they had excluded Niemann-Pick A, B, which is a variant sphingomyelinase deficiency. But there's blood-based tests to do that. But they didn't get to NPC because, that would have taken this extra major step. The other approach is molecular testing, and that requires a high degree of suspicion, and it's relatively expensive. You have to really be thinking about NPC1 to send off for sequencing of the NPC1 gene. Now, whole exome sequencing is also changing this dynamic, and we're seeing individuals diagnosed by whole exome sequencing. I hate it as a geneticist, but tests where you don't have to think actually get done, and the diagnoses get made. If you have to think about it, then oftentimes the diagnosis doesn't get made. But the test that we developed was based on plasma oxysterols. These are non-enzymatically produced oxysterols. Turns out in NPC, we think you have an intersection of storage, especially in the liver, of free cholesterol, and you have oxidative stress, and you end up with this production of these non-enzymatic oxysterols. The one that's probably the best diagnostic marker is this 3-beta, 5-alpha, 6-beta cholesterol or triol for short. And these, you can see it's markedly elevated in NPC compared to controls or heterozygous patients. We extended these studies, looked at a series of other lysosomal storage diseases. This is an NIH experiment. I walked around and said, what do you have in your freezer? And came up with a whole series of other lysosomal storage diseases where I could get a small amount of blood from them. And then in a larger study, we can show that it has good sensitivity and specificity. And this has really moved into about 30 laboratories now and is sort of becoming the primary diagnostic test for NPC. It's not perfect. It does pick up NP A and B, but I'd be happy, you can sort that out real quick if you have a positive there. So what about therapy for NPC? And the drug I'm going to talk about is this drug called 2-hydroxypropyl-beta cyclodextrin. And to refer to it as a drug is sort of odd because it was actually developed as a pharmaceutical excipient. And what do I mean by that? It was used to dissolve drugs. It's a cyclic oligosaccharide with a hydrophobic core, and the oligosaccharide will allow it to solubilize in water, but the hydrophobic core would allow it to bind hydrophobic drugs. So it's a good carrier for hydrophobic substances. And it turned out that Cindy Mellon's group was looking at the NPC mouse, and in NPC, your cholesterol is blocked in the endolysosomal system. So the rest of the cell is actually cholesterol starved. So they sort of hypothesized maybe there's a defect in neurosteroid formation. And they looked and they found that there was a deficiency of neurosteroids in the NPC1 mouse. And so they said, well, if there's a deficiency, what happens if we treat? Well, this is allopregnanolone, and it's like many sterols, it's not really water soluble. So, well, how are we going to solubilize this? They solubilized the allopregnanolone in cyclodextrin. And they injected the mice with, at various days with the allopregnanolone and cyclodextrin and got this remarkably increased survival in animals, especially if they started treatment young. So that was really interesting. Okay, is allopregnanolone potentially a therapy for NPC? A number of other labs started looking at this, including Kristen, who's sitting in the back here. And they quickly realized, well, it's not the allopregnanolone, but the cyclodextrin actually is the active substance here. And the two labs were Kristen in Steve Walkley's lab, and then Benny Liu in John Dietschy's laboratory looked at this. Both labs showed increased survival of the NPC mice treated with cyclodextrin, and they could show pathologically there was improvement in the cerebellum. And in NPC1, you lose the cerebellar Purkinje cells. And these are cerebellar Purkinje cells stained with calbindin. You can see the cell bodies here, and then the cell processes. In NPC1, you have loss of the calbindin-positive Purkinje cells. And when you treat with cyclodextrin, you have restoration or preservation of the cerebellar Purkinje cells. So this was reverse the pathological changes and improve survival. Charles Veit at University of Pennsylvania has a cat model of NPC1. And this is a clip of a kitten treated with intrathecal cyclodextrin, a kitten treated with another drug called miglustat, and then you'll see an untreated NPC1 kitten here. This jumping around, but this animal will soon have to be euthanized. And these cyclodextrin-treated animals can live out to 2+ years now. So it was pretty remarkable, the degree of survival, preservation, and lack of Purkinje cells and lack of symptoms in these animals. So the question was, how do we make that work in the kids, and can we translate that from the laboratory to the clinic? In telling this story, I want to talk about one biomarker that we've developed, and it's a pharmacodynamic marker, and I'll explain what I mean by that. And the biomarker is 24S-hydroxycholesterol. This is an oxysterol. In contrast to the other oxysterol, it's an enzymatically produced oxysterol. So when cholesterol comes into the cell, it's taken up, gets into the endolysosomal system. It is, by the action of NPC2 and NPC1, it's moved out of the endolysosomal system and it becomes bioavailable to the rest of the cell. When cholesterol is in excess, it moves to the endoplasmic reticulum, CYP46 in a neuron, hydroxylates it, forms 24S-hydroxycholesterol that then can move out of the cell and into the blood, and then is degraded by the liver. It turns out that 24S-hydroxycholesterol is specific for neurons of the central nervous system. The rest of the cells in the body make another oxysterol known as 27-hydroxycholesterol. So 24S-hydroxycholesterol is a marker of neuronal cholesterol homeostasis. In NPC1, you have a block in the efflux of cholesterol out of the endolysosomal system. So the bioavailability to the rest of the cell goes down. And what we were able to show in NPC1 kids, when you age match them for controls, there's actually decreased serum levels of 24-hydroxycholesterol. What we propose is when you give cyclodextrin, that it helps move the cholesterol out of the endolysosomal system. We don't know exactly how or what the mechanism is, but circumvents this block, makes it bioavailable to the rest of the cell, and we propose that if it became bioavailable to CYP46, we'd see production of 24-hydroxycholesterol. And this is an experiment done in the mouse model, a single intraventricular injection of hydroxypropyl beta cyclodextrin, and you can see increased production of the 24-hydroxycholesterol compared to a saline injection. So this is a pharmacodynamic marker that we can use to ask the question, if we give the drug to the kids, are we having the biochemical response that we expect? So how do you get this drug to the kids? You want to get it to the brain. Another problem, like cholesterol, it doesn't cross the blood-brain barrier. So the initial approach that we used was what's called an Amaya reservoir. An Amaya reservoir is basically a small reservoir or bubble that sits under the skin on the skull and has a small catheter that enters the ventricular system. Amaya reservoirs were actually invented at the NIH in the 1960s, so it's not new technology. And it was used to treat central nervous system infection, fungal infections, because fungal drugs can't get in, and then central nervous system tumors. So that was our first approach. We started out giving the kids 50 milligrams of cyclodextrin. There were no drug-related adverse events or reactions. And 2 out of 3 patients, they all had a positive response when we looked at the 24-hydroxycholesterol, but 2 out of the 3 actually had what we had defined as a significant response, which you can see 3 and 4 times greater than the standard deviation. And you can see here that the area under the curve of the treated is higher than the control with just the saline. Problem is we ran into P. acnes colonization, infection colonization of the Amaya reservoirs, and that stopped us dead in our tracks. That may have been bad luck. It may have been a predisposition in this rare disease. We don't know. So we switched the approach, and we went to a much simpler approach, although it put us further away from the brain, and that was to do what's known as a spinal tap or a lumbar puncture, in which case we introduce the drug at the base of the spine into the CSF and are relying on it to move up to the brain. Okay, so 14 subjects were enrolled. They get monthly lumbar intrathecal administration. It's an open-label dose escalation study. It's a phase 1/2 study, so it's really focused on safety, biomarker evaluation, and we are looking at clinical efficacy, but that's not the primary goal in a phase 1 study. In a phase 1 study, you're really focused on safety. To date, dose range that we've studied is 50 to 1,200 milligrams of cyclodextrin lumbar IT, and dose advancement was based on safety assessments. And here you can see our mean doses at 12 and 18 months in the patients. Safety is a primary consideration. The issue that we ran into with cyclodextrin is ototoxicity. It was actually what we call an expected adverse event. We knew from the mouse, the cat, and also a preclinical dog model that cyclodextrin was ototoxic. It's variable. It impacts mid to high frequencies, and here you can see the variability in the various patients. But to date, it's really had minimal impact on quality of life, and you can correct the issues with a hearing aid. So you have to put that in context of a lethal disease. High-frequency hearing loss is part of NPC. About half of our patients started the trial with significant high-frequency hearing loss, but definitely after they've been in the trial, we've moved all the patients down to where they would be candidates for hearing aids. Do we have target engagement? When we looked at the 24-hydroxycholesterol, worked much better in the mice and the cats. Humans just tend to be more variable. We tended to have positive responses in the serum, but we had a lot of variable responses. And this is just 2 patients at 900 milligrams. But here are the same 2 patients at the same time, where we're looking at the CSF 72 hours after the dose, and we can see both of them respond with abduction of 24-hydroxycholesterol. Potential clinical efficacy. We used the neurological severity score that I told you about. We would predict 2 points, progression of 2 points per year. And here's the data from our study out at 6, 12, and 18 months. And you can see that we've moved these kids away from the predicted progression rate. Small study, so you always have to deal with issues of all of a sudden we have this patient who definitely progressed, and it progressed at what looks like an accelerated rate. It turns out that that patient is the oldest subject in the study, most severely affected, and because of multiple issues, we had multiple dose interruptions with him. And if you actually back his data out, you can see that we actually flatten this curve out even more. So this data, it's an open study, but it's very promising that we're seeing this. Realize it was a dose escalation, so we're only probably getting to effective doses towards the end of the study. But it formed the basis for breakthrough designation for this drug by the FDA, and it formed the basis of a phase 2/3 controlled trial that's now enrolling and ongoing. A lot of people contribute to this. This was a major collaboration between NCATs and intramural investigators from multiple institutes, but it also involved extramural sites, and I'm just showing the principles here on this. But it also involved industry, Johnson & Johnson initially, and I didn't update this slide, but Vitesse has now is a company formed specifically to take this through the phase 2/3 trial. And then finally, a thank you to my lab, and a definite thank you to the patients, and that's the whole reason we're here. Thank you.
Okay, well, thank you very much. That was, well, do you have some questions or comments about this? Do you all work in this field?
Actually, I'll embarrass her. Kristen does. She performed the mouse survival experiments, one of the labs in Chris Walkley's laboratory. And you're also responsible for salvaging the cat model and getting it to the University of Pennsylvania. She drove across country with those kittens. I assume they were kittens at the time.
So how was the cat model generated? Do you see a future for CRISPR approaches to this 5-10 years from now, early?
You know, in terms of actually trying to correct the particular defect, I think you would have to combine it with a cellular-based therapy.
Yeah.
It's going to be difficult because of the number of different mutations. The most common mutation only accounts for about 15% of the alleles. So, and a lot of the mutations are private. So you'd have to do a lot of development in terms of individually trying to produce the reagents that would work in a small percentage of kids.
So a prenatal screening.
So,
I mean, should this be part of some legal mechanism where every child born and screened?
Newborn screening is as much political as it is rational.
Yeah.
So we have developed, the trial works okay, but there's a new variant now that's a bile acid derivative that we've developed and will be coming out soon, developed in collaboration with Dan Ori at Washington University. And that works really well on dried blood spots. So it's absolutely feasible to have a newborn screen. But then you're into politics of newborn screening in terms of getting them on the list and then getting states to accept it. And then getting enough people to actually deal with, because it's not all cut and dry. Now you have a screen and you bring in everybody. So now you may be bringing in kids that weren't going to get the disease until 50. And so what do you do with them, and trying to sort out how you handle the actual positives there. So that's really a genetic counseling and political issue.
Are there
As
any
well as economic.
questions? Yes, here, please. No, use the microphone so people can hear you elsewhere.
So for the patients that are that were in the phase 1 trial, and I assume are continuing on, as like on the sidearm or whatever, are you going to continue to follow are they still being evaluated, and that you'll be able to see their severity scores?
So we're still, we're starting to get 2-year data on a number of the kids. So from a practical manner, the phase 1 patients will move to what we call part C of the phase 2-3 trial, and realize coming to the NIH and living a quarter of your life here is a sacrifice on these families. So we're trying to identify the phase 2 sites that are closer to them, so that's a little more practical. But we will continue to bring them back at the yearly half-year intervals. And they're also a very good source for long-term safety information still.
All right, listen, I want to thank you both very much. This was really very exciting and informative. Very good.